Inflammatory syndrome. Sorry, there. Oh, okay. And can everyone in Zoom hear me, or do I need to move this closer?
You can move that chair.
That's true. I don't know why I thought about moving the table.
We can hear you.
That's
Don't worry, it's cheap.
like double chin and whatnot. Okay. Oh, right. No, they didn't respond, so I'm gonna go with they can hear me, but just aren't listening. So. All right. So this first article, like I said, the title is Socioeconomic and Racial and/or Ethnic Disparities in Multisystem Inflammatory Syndrome, or MISC. And it's by Karina Javalkar et al. The objective of this article was to characterize socioeconomic and racial disparities that impact either the diagnosis and outcomes of MISC in children. So in terms of the importance of this is, for one, our patient population is primarily people from underserved backgrounds and minorities. So I felt it was important to kind of touch on that. And the patients that we serve also in the hospital, not just in the clinic. And then along with the pandemic in general, it's shown that racial and ethnic socioeconomic disparities with COVID in general, and also there's been shown in the past that people from socioeconomic or lower socioeconomic class have been shown to have impact on multiple pediatric diseases. So this article kind of shows the importance to further characterize and the impact of social and economic determinants of health and racial disparities. Okay, so the methods of this study, this was a retrospective case control study, and they used patients who were diagnosed with MISC, and they used the definition classified by the CDC, and they only used pediatric patients whose age was less than 21 years old. They took electronic medical health records at Boston Children's, Mass Gen, and Boston Medical Center, and then compared the impact of socioeconomic status of children with MISC compared to children with MISC in 5 other groups. The first group was children with COVID-19 infection. And so they actually, for these groups, they excluded all people who were officially diagnosed with MISC. So the first group was children who were diagnosed with COVID-19, regardless if they were symptomatic or asymptomatic. And these were cases from January 1st, 2020 and July 1st, 2020. The second group was the MISC rule-out group. So they thought they might have MISC, but then were ruled out and found not to have it. And then the third group were children who were hospitalized for a febrile illness, and that did not include COVID, did not include Kawasaki, and did not include MISC. And those were children who were hospitalized between January 1st and September 1st, 2020. And then the fourth group were children who were diagnosed with Kawasaki's disease, and they chose between 2010 and 2016. And then the last group was based off of the 2010 US Census in Massachusetts of just children in general. And so based off of how they collected that, when they were looking at race, they were looking at self-reported, like what patients came in when they were diagnosed, how they reported themselves to identify as. And because race and ethnicity are complex, they grouped them into specific categories. And so they used the categories that they also use in the census. So they did white, Black, Asian American, or other. And then when it came to ethnicity, it was either Hispanic or non-Hispanic. then used a neighborhood socioeconomic status summary score and a social vulnerability index. So I'm going to refer to those as SES and SVI, so I don't have to say that over and over. And they calculated that based off of patient addresses using the 2010 US Census. So they used the neighborhood SES summary and reported that as Z-scores, and then summed all of those to determine the overall neighborhood SES score. And then in terms of SBI, that was reported as a percentage, and the higher percentage was characteristic of increased vulnerability. And then in terms of statistical analysis, so they took the SES summary score and the SBI scores, and they were compared across the different groups using a Kruskal-Wallis test. And then the proportion of patients who were in the lowest SES quartile and the highest SBI quartile, so similar groups, they kind of used that in addition to their race and ethnicity in each group, and then compared those using a Fisher exact test. Then they used logistic regressions to determine the impacts of socioeconomic status and SVI, while including their race and ethnicity in children with MISC. And then patients who had MISC that were in the lowest SCS quartile and the highest SBI quartile were compared to the others using those same tests. So the Kruskal-Wallis test and Fisher exact test. So the first group was just kind of determining a baseline, and the second group was determining people with MISC, so kind of like cross examining them. So the results, they noted that in the study, there was a total of 43 patients, and they were diagnosed with MISC. 44% of them were Hispanic, 16% of them were white, another 16% were Black, 5% were Asian American, and 7% were classified as other. And so in terms of the association with SES and SVI and race, they determined that neighborhood SES summary score was significantly lower in patients who were diagnosed with MISC than for all of the other groups except for children who were diagnosed with COVID. So it was significantly lower for patients versus those who were children in Massachusetts, children hospitalized with febrile illness, and children with Kawasaki's disease, and children with MISC rule out. The SBI also showed the same significance, that they were significantly higher in patients with MISC than for all of those other groups. So that was showing that patients with MISC and COVID were more likely to be from racial and ethnic minority groups, mainly Black and Hispanic, compared to children who were hospitalized with febrile illnesses, MISC rule out, Kawasaki's disease, and the children in Massachusetts. When they looked at the multivariable analysis, it showed that SES and race or ethnicity were independent from each other, and that there was a higher risk just in both of those separately. And it was specifically as well in Black and Hispanic children. And so really what that means is that Black and Hispanic children, regardless of where they rank in the SES or where they came from, had significantly increased odds of developing MISC. So kind of looking at this article in general, it, just like we just said, the patients diagnosed with MISC, they had lower SES and had increased SVI, and those patients tended to be Black and or Hispanic. And I thought kind of the most important part that they talked about is the correlation seems to be with people from those backgrounds. They were unable to work from home during the pandemic, and more likely had to use public transportation. So they had a higher exposure rate to COVID than others. And then although the SES and race were correlated, it did still seem to be an independent risk for MISC. And they did adjust for the SES using 2 different measures to show that they were independently related. So another thing that I thought was kind of interesting is that in China, Japan, and South Korea, they didn't have, even though they have really, really high rates of COVID, they didn't have high rates of MISC like we see in America, which kind of led them to think that maybe there is a genetic predisposition in African American and Hispanic children. So that is one of the things that they could look for in the future to kind of figure out why that is. And something in terms of not really including in my practice, but I feel like we can use socioeconomic status, and I mean, even just in chalk, knowing where our kids' backgrounds are from, just being proactive with things when children are diagnosed with COVID, and having them come in again to check in on them and kind of following up their outcomes afterwards. And one other thing that I liked that the article pointed out was that a big thing to be able to help combat things like this are just advocacy within pediatricians against racism, discrimination, and implicit bias. So one of the limitations from this study is obviously the sample size. It wasn't a very big sample. It also was in Massachusetts, which is not very much like South Carolina. And it's not. And that when they use the control groups, they only use the control groups at Boston Children's Hospital versus the rest of the study was including Boston Children's, Mass Gen, and I think the third hospital that I can't remember. Even though they did look through all of the patient samples and saw that they were equivalent to each other in terms of like racial backgrounds, and so the samples looked like each other, but they were different. The people who were involved in the study were not necessarily blinded to the study, so it could inform some implicit bias. Yeah, I think that's really about it. Any questions?
Do you happen to know, and they might not have mentioned it, like you said, they only use the control from Boston Children's, what the patient population of Boston Children's versus Mass Gen looks like? Like, is it from certain neighborhoods? Okay.
Yeah. So
I heard you say that, but I wasn't sure if they like still controlled for all of those.
Yeah, they controlled for all of those things. It was just something that they pointed out that technically the groups were different, but they were very similar in their background and everything.
You know, I thought this article was very timely, especially with our grand rounds that we had about a week or 2 ago, looking at social determinants of health and the factors that you just talked about. I found it interesting because it really, though, looked also at the disease relative to obesity and asthma, and then they threw in that Korea. And then my first question, well, what is the obesity rate in Korea? And then all of a sudden, you know, it becomes not Korea versus, you know, genetics of it's obesity, which my mind's eye in Korea is the obesity rate is not as high as the United States. I don't know that, but just, you know, and so I'm going, well, yeah, it's the obesity and the asthma that, you know, although those also parallel socioeconomic status, you know, things too. So it's kind of interesting in that perspective.
For me, I think the things that, at least for me, gave a real pause about it were the, you know, went through, if there was disagreement, right, their adjudication process was basically they just argued about it and decided it was right, and that was that.
Yeah.
And didn't use anything that was necessarily hard and fast to say, well, this is how this is going to play out ahead of time, just structuring it. And then, some of the, and I'm glad they actually mentioned this in their conclusions. They talk about, areas that this could impact about vaccination rates and trying to prioritize and things like that's all great. But using the 2010 census data, using the census data in and of itself and self-report in and of itself is a little problematic because if we're led to believe what we're told, the people most at risk or least likely to participate in censuses are those that are at risk, right? Those in lower socioeconomic status. And so this might underrepresent some stuff. It may actually be a little better or a little bit worse than what we think because maybe the rates are a little worse. Maybe the status of these people that are living in these areas by this vulnerability index actually a little bit worse. So I think that census data is something we'd love to have something a little more hardy, but you're never going to get it. So it's a little hard to understand.
The other thing is census data doesn't include your migrant workers and your
Yeah,
illegal immigrants
that's
and
true.
all of those people, which quite frankly all live together and have a lot of risk factors and may be more affected than we believe.
Yeah, and this doesn't take into account like multi-generational families, like that increases your risk if you've got COVID, right? If grandma's got it and uncle's got it and everybody's living in the same house, that when you think about our people with different cultural backgrounds, they do mention that patients of these immigrant populations was a higher risk for them. So those kind of things clearly play an impact if you get COVID. Well, if you get COVID, you're at risk for MIC for our patients. So.
And did they mention that they suspected that it was because of one of their maybe kind of assumptions was that this group can't afford childcare, therefore they have to be in public transit, and so therefore they're exposed. They're more likely to be exposed.
In
that was
a
just part of their
roundabout way,
discussion?
but
That's kind of what they said.
Yeah.
Right, and it's like that's quite a
Transportation.
assumption, I think.
I think it was
probably
more
in ways it's
so.
probably accurate, but it's also
Yeah.
like that wasn't part of it.
Yeah, I think it was more
It wasn't
so
public transit
because
study.
of like their financial background that more of those people who live in neighborhoods of like higher social vulnerability index do use public transportation. Because we even see it in Chalk, like people come on buses or cabs, and so their risk is already increased just because they have to use those means because they don't have cars.
Yeah.
Yeah.
There's those odd assumptions just kind of thrown in discussion when there are so many
Yeah.
things to associate
Yeah,
build
yeah.
that exposure. Yeah, transit's one thing, it's 1,000 other things. But
I feel like when I did my grand rounds on this, it's like obviously so socioeconomically unfair, but also like how many more African American children have COVID than white children is impressive. But then just like the percentages, the amount more that end up with MISC are also is like so much higher a percentage than just the amount with COVID. So like I was trying to talk to Dr. Dingle about it and I was like, oh, like autoimmune, like African Americans are more susceptible. And she said, no, it's because it's like more autoinflammatory than autoimmune. So I feel like you said like we have to like look for something that points to it, whether it's genetic or not, because like as unfair as socioeconomics are, like that can't be the only thing when there's this much more. And I didn't know if talking about census things, if just like really we're just like some African American people don't have enough access to healthcare that we're not initially diagnosing them with COVID, and really those numbers are way higher, but they get sick enough with Miss C that they have to get hospitalized, and that's why that is such a big jump, which would then make you look back at COVID and say, well then how horribly racial despair is this? So I don't know. I thought that was interesting too, that it's like socioeconomic status obviously has a big impact, but also like we can't stop looking there because maybe there's like something else that lends towards that. And I don't know. And maybe you look, you're looking for something because this, I don't think this was out when I did mine.
No, this was new. This was like last month or 2 months ago, I think. But there was just this page that mentioned kind of the rates in children, and then I wrote down, of course I can't freaking find my little, oh, here it is. Yeah. the breakdown in, which I thought was just kind of crazy, the breakdown in the percentage of just how many children and their race in the United States in general, and then how many got MISE. So white children make up 50% of all US children and only made up 19% of all MISE infections. Hispanic children make up 25% and they made up 37% of all MISE, and then Black children only make up 14% of the population and accounted for 34%. And so I feel like even with like misdiagnosis and stuff, that like 50
It's a
versus
huge
19,
wild
it's
difference,
so
yeah.
crazy. Yeah.
Yeah, I was like caught up on that and then
Mhm.
wasn't gonna make it. That's not what my
Yeah,
presentation was supposed to be.
yeah.
It's like, it was pretty impressively different.
Makes you wonder if in like 10 years, somebody's gonna come out with the epigenetics of things, like somebody's like banking some of this blood to look at, okay, are there genetic things,
Yeah.
right? That are
Well, 'cause-
gonna impact, like, because epigenetics is something that's happening
Mhm.
right now for larger centers. And so are they gonna be able to say, well, this, gene sequencing in patients of African American background or Hispanic background are more risk for MIC because of these genes. And
Yeah.
it wouldn't change anything, there's nothing to cure because of it,
Yeah.
but at least it gives you some idea as
Like a
to
reason
their
why,
impact
yeah.
outside of SES.
And you almost hope it doesn't, because
Right.
you stop
Yeah.
focusing on
Yeah.
socioeconomic
Yeah,
status.
true.
Like, but
That's how you go.
no, it would be
Yeah.
good. Like it would be good.
You
But
would
like,
be
also,
good.
like it will make like people be like, "See, we told you." Which is not
You
fair.
are different. Yeah. Just kidding. Just kidding.
I think just biostats wise, like looking at, this is a case control, it's a good one just to store in your head, and you'll get a lot of questions about like what case, what study it was. But these are gonna be where you take an outcome and you look retrospectively back. And so you can't necessarily, you wouldn't from this case say, you can say association, but not causation. So I think this is a good one to kind of store in your head, whereas on other case controls, we often want to say that it caused, but you can't. You can't say that smoking causes lung cancer if you looked at lung cancer in back. Does that make sense?
Yeah.
And so if you keep this one in your head, it's kind of nice to be able to, on the boards, be able to have that as your answer.
All right.
The obesity rate in Korea is 4%.
Ooh.
48.4 something.
So the stack, you mean
That-
the deck is stacked against America. In America, the deck is stacked
So
against
it's
Black
4%.
people. And
Yeah.
it's not- yeah, it's real fucked up. And in
Not getting
Colombia,
better.
the deck is.
Versus 48% of America is simply the obesity. Simply the obesity.
Yeah, we're with you.
Okay.
Because they don't have Americans.
Drink break.
Drink break.
I really got to that one.
It doesn't matter, because
No,
like,
you're so
Now my brain like, oh God, let me know.
Nice to see you. I feel like we've talked all day today. Yeah, that's I tried to forget this one.
You okay? Oh, like brain freeze or? Okay.
Coming by, I'm going to be there, so
It's very.
I'll be there.
I love it. Just my baseline.
Oh.
Oh, one of those.
So I've gotten 4 texts. What is that beeping?
Is there something beeping or is there something wrong with
I cannot hear it.
I will not be down. You haven't heard it?
No, I have
You're
this
very
beeping at
stressed.
my house. No, I have this beeping at my house, so I tune it out. I don't hear it.
You need to change the batteries in your fire alarm.
No, I know. I changed the one that's specifically in my room, so it wouldn't be in
While
my
you were
room.
sleeping.
Yeah,
Smart.
but all the other ones in the house, I just ignore.
I worry about the smoke station. Hey, you never saw where you were making the page that expressed all of my, I made the same thing.
I tried to take it out of the wall, but it wouldn't disconnect, so.
Is that also the
Probably.
Probably carbon dioxide right now.
I know. I don't wake up. They're taking a drink break.
I haven't watched it yet.
I could do it with one leg.
You can do it with us.
I'll just switch it to more like an episode.
Somebody's making a target.
I have the batteries for the ones in my house, but they're all too tall. So I need to have someone come and change them.
Jeremiah,
You have a chair?
No,
Yeah.
like
Just stop.
20 feet in the air, tall, not. Because it's in the part that's like the two-story part of my house. Those ones are big, which is just, I feel like that's poor design of house people. You
Yeah.
shouldn't have put it on the ceiling.
You guys aren't paying me enough. You gotta fix the lights and shit too.
Yeah, like it's gonna take a while to get to 20 feet, like that's.
And I don't throw around the word retirement home often, but it make you look like you had been served your tray for the evening and
Oh.
you're ready to watch it.
By a nurse, not like a butler, by a nurse.
Getting in bed at 6, gotta wake up to swim at 3. And Neicey goes first.
He's already wearing
To
a
do
bathing
what?
suit.
To swim a mile with them. Oh.
I can swim, actually.
I have to show you what.
Don't, just, I didn't say it for you, that was just to him.
Dr. Staple.
Yeah,
is
Sue was just
listening to you right
She
now. All right.
Dr. Staple, can they hear us?
Yeah.
Oh
my God.
All right. So this next one.
Is there any way you could turn the
Next to
volume
last.
up on that? I want it to feel like it's inside of my
There's
mouth.
nothing next to it.
I mean, I
Still
hear it in the background, but I'm just so used to
I'm
tuning
gonna go
noises
do
out
this.
because I live
Go
with
do it
one
now with those
children.
long legs, you should be able to reach
I
out.
used to tune out things that aren't important.
She's gonna do this paper.
Yeah.
Well, I'll
Dr.
do that in a
Hahn, get on Jeremiah's shoulders, and then we'll get a ladder.
Perfect.
You could probably just step on the
It's
stairs.
Oh, is that what I was thinking?
It is not. It is not.
Jeremiah already checked that one
I'm
out.
already keen into this crap.
Oh, you've been looking at the beeping?
All right, next
Thank you.
Knock it out for pride. Here we go.
Yes, so this I thought was very important because it is Pride Month. I mean, in general, it's important for all of us to learn about this at any time, but very timely. So the name of this article is Experience of Chest Dysphoria and Masculinizing Chest Surgery in Transmasculine Youth. So this was a modified ground theory, which I did have to look up, and I will be talking about that later. A modified ground theory study, which also was a cohort study of transmasculine youth aged 13 to 21. I think I might have jumped ahead, but we'll come back to that. All right, so the importance of this study, the biggest thing that I thought was, for one, within the transgender population, there's disproportionately high rate of depression, anxiety, suicide, and that alone makes it a very important topic to talk about. And chest dysphoria is one of the things that a lot of transmasculine youth talk about as being one of the things that contributes to their depression, anxiety, and suicidal. I did hear it that time. Suicidality. So one of the things the article pointed out is that in 2018, transmasculine youth had the highest prevalence of reported suicide attempts, in that about 51% of transmasculine, and not transgender, transmasculine in the sense of children who are born female who identify as masculine. But within that group, 51% had reported suicide attempts. And one of those things, like we talked about, is chest dysphoria, which is the physical and or emotional discomfort and distress caused by the presence of breast tissue. And then they also talks about that early use of gonadotropin releasing hormone agonists can help to prevent breast development, but by the time these children end up coming to, oh, it says your internet connection is unstable.
Cheap ass
Okay,
Wi-Fi.
never mind. That it, that they already have breast development that is irreversible. So a lot of, not many studies have been done on the experience of chest dysphoria, which is another reason why this is important. So methods like we were talking about. So they looked at children who were 13 to 21 who were assigned female sex at birth, but identified their gender as male or on the masculine spectrum. And they only looked at children who endorsed having discomfort or distress about their chest, and ones that also had notable breast development. And so they used the Tanner staging of 4 or 5. This was done at Children's Hospital of Philadelphia and in their gender and sexuality development clinic. They did exclude any of the children who had undergone top surgery within the past 90 days, just so within the healing process, they didn't want that to skew how they actually felt about it for the long run. And then they also excluded ones who, if their primary gender affirming care provider was a part of the study, they didn't include those children either to remove bias. So they looked at EHR reviews and then conducted studies and interviews with the children. So the interviews were either in person or they were via video. And it was a one-on-one structured interview just to talk about kind of their experience and their thoughts about masculinizing chest surgery. So afterwards, all of these children did complete a survey and they were given a $40 gift card. So they wanted to add that in just to make sure that there was no, yeah, no. Okay, and so then this is where we talked about them using the modified ground theory approach, which I'll go into more at the end, but basically they took certain themes that the children all endorsed and tried to make it more quantifiable off of the qualitative like data that they got. So the results from that, they did 16 interviews, but the results from that, they said there was 30 youth enrolled and that completed the visit. 16 of them had not had top surgery, and then 14 of them had undergone masculinizing chest surgery. Of those, there was no, between the two groups, they were pretty equal in race, age, ethnicity, or yeah, race and ethnicity, age, and their insurance status. Of that, they were predominantly white, non-Hispanic, and privately insured. Of the themes that they obtained from interviewing the children, they had, I think, 8 in total. And theme 1 that they, from the results, were that chest dysphoria caused strong negative emotions, including suicidal ideation. Theme 2 was that most of the youth did endorse feeling helpless. Theme 3 was that they had chest dysphoria as an intrinsic phenomenon. So they, not only when they were out in public, they also had distress while they were alone and no one was around. Theme 4 is that chest dysphoria caused functional impairments, and that went from anything including actual physical activity and limitations with sports, but also social avoidance and their interpersonal relationships. is that most of them agreed that chest binding was a trade-off between the physical and psychological discomfort. So even though it was very painful is what most of them talk about, the pain was worth them feeling better psychologically. And theme 6 is that masculinizing surgery was viewed as critical to their quality of life and functioning, but that there were a lot of barriers to accessing that surgery. Theme 7 was that youth experienced resolution of the chest dysphoria and improved quality of life and functioning after masculizing chest surgery. Theme 8 is that chest dysphoria is a large component of gender dysphoria within these children, and it's not adequately addressed by just testosterone alone. So, limitations, or well, I guess we talked about this study. Overall, it reveals that chest dysphoria was a critical component of gender dysphoria, and it led to extreme suffering and functional impairments, and also contributed to suicidality. And that on the flip side, after having masculinizing chest surgery, they had tremendous benefits from it, including mood, confidence, quality of life, and functionality. So within the 10 youth who had masculinizing surgery as minors, they had no regrets when they looked back on it, even though they were under 18 when they got their surgery. And then a thing that we kind of touched on earlier is that even though once children do come to, well, not really our clinic, but any of the clinics that do focus primarily on transgender youth, they get started on gender affirming hormones, that it didn't do anything to help their chest dysphoria. But kind of ironically, it ended up worsening their chest dysphoria. And they touched on the fact that it's not due to the actual testosterone, but it's due to once the testosterone and they're on those hormones for a while, it kind of alleviates all of the other problems that they were experiencing with gender dysphoria, but their chest is obviously still there. Another thing that the article touched on was that for some insurances and surgeons, they do require testosterone therapy for a certain amount of time before masculinizing chest surgery. And in that time, it could cause harm because there are children who obviously are still suicidal based off of chest dysphoria. And recently, which I did not know that until this article, that there was legislation where 14 of our states in America prohibited prohibited gender affirming medical and surgical care for minors, which goes completely against the guidelines that we have for treating transgender youth, and against the American Academy of Pediatrics. So some of the limitations, well, for one, was that the population is privately insured and white children. So it's harder to use that population on the population that we see here. And actually, Dr. Zadak was talking with Dr. Hahn, and we do have 40 children in the transgender clinic that she runs. I don't know the exact breakdown of
didn't
it.
get the breakdown, but
Yeah.
the 40 patients in it was surprising.
Yeah, and that's just in the little town of Columbia, and the ones that actually are able to go to her clinic and were recognized. So that was one of the patients. And then I thought that it was, I guess, kind of weird that they automatically excluded anyone who didn't have issues with, or didn't have chest dysphoria. So they never touched on that at all. They only included children who experienced the discomfort, whether that be physical or psychological with their breasts. So in terms of practice change, I personally right now have a practice, but I think in CHOC we could, because I know in the OB/GYN clinic and PAG clinic, they actually ask children what pronouns they go by, and even just that kind of creates a more welcoming space and kind of makes them know that they're included in that we are thinking about that. And I was looking, I don't remember what other article I was looking at, but it was talking about, actually, I think it was the guidelines of transgender youth, that question alone makes children feel just more comfortable in your practice. And that'll help create more of a culturally sensitive environment for them. And another practice change, I guess, based off of this, I know, I mean, it's a little bit different in the South, but in a lot of states, they require mental health services before you can even like proceed with anything in terms of hormones or anything like that. And I think it should be kind of a like a beneficial thing where you do them together, but not that it needs to be required, because it can delay children being started on hormones to where now they have irreversible breast tissue, which would lead even more into chest dysphoria. That's it for that article.
It's a 1 year of psychiatric evaluation in South Carolina.
It's kind of like bariatric surgery.
You have to prove you're not
Really long
crazy,
time.
which is just wildly inappropriate. But yeah, I found that out.
A year is
That is a
A
long
year is a long time, and it's
Yeah.
not like recurring evaluations or anything. It's not like the kids gonna change that.
That is a very long
And
time.
it's a long time to feel
Yeah.
badly about yourself.
Right.
Yeah.
And I feel like you're having to prove yourself.
Yeah.
Yeah.
It's like, this is myself, I shouldn't have to prove.
And getting bullied the whole time.
Like, but also, does the, I'm assuming it's CBT therapy actually help any of these kids? Like, that wasn't spoken about in the article at
It
all.
wasn't, but I was looking at some of the other things and it doesn't. No one is like converted. Like that's not even a real.
I don't
Yeah.
expect anybody to be converted, but
Yeah.
like, it would be nice if it would like help them feel better about their body image. and
Mhm.
Or they're,
have a drink.
Do you know if any of these patients that went through their surgeries have had it before at all? Because that might inform some of what Ashton's asking, right?
Yeah.
Because 10 of the 14 that had not gone through the surgery felt good about the outcomes
Mhm.
and everything.
Was
if
it
they had it
because they-
before,
Yeah.
then maybe it reaffirms the fact that, okay, yeah, this was the right decision.
Mhm. I don't know if these children in particular, but when I was going through the like clinical guidelines for transgender youth, they did mention that the children that were in therapy tended to continue therapy afterwards, and it was more to have someone through each transition. So they just like had someone there that they could talk to about it, and it facilitated kind of the discussion with parents as well, when they kind of like don't know what to do or how to interact with their kids. So
These are some policy statements. and
What's really,
Office-based management.
what's really interesting is that with Epic, I don't know if Starter could do this, but like with Epic, you can actually flag a chart as like
Yeah.
a patient being transgender and like mark their pronouns, and it, like when you open the chart, it pops up and it says like,
Yeah.
this patient is transgender and uses he, him pronouns.
It's for every patient we even have in the NICU.
Yeah, and it's
Oh,
wonderful.
so-
And then if
Yeah, I know, I was like, we're just gonna go with what we were finding for now, we will sort out the rest later.
But I think that's wonderful because it does give you, you know, the opportunity to talk, and like, since it's
Yeah.
in the chart, it's something that you can easily like of our, chart documentation. I wanted to talk to you about what pronouns you would be comfortable with me using during your visit. And then you can enter them into the chart so that they're there for everyone else to.
I feel like I always have like 12 things to say, but I feel like I have like 12 things to say. And first, when you're like, oh, I don't have a practice, but like at this place, at PAG, they always ask pronouns. And it's like, as a understanding but privileged person, I'm like, oh, like I don't want to ask pronouns because 99% of people, or whatever, 99% of people don't need their pronouns asked. But when you said it, like it improves like cultural understanding in those people, it's like, yeah, because if those people don't have their pronouns asked, they're not going to understand that people need their pronouns asked, which is what basically all of us, and certainly our parents don't understand. And it's like, if you don't do that, then like who is going to do that for those people? And the people that like another nail in the coffin of this, of who we consider normal people, which that's not what it is, but like, oh, if those people don't understand, then how will these people ever not have chest dysphoria? And then my next thing I want to talk about is, you called it CHOPS, gender and what clinic?
I just read the exact
I know, but
name of
say,
it.
like, if you can say what it's called, it's like,
It's like gender and equality or something like
right,
that.
so if they have a gender and equality clinic there,
Yeah.
and all we have here is our endocrine office, and like the kids that live 2 hours west
Gender
of
and
here,
sexuality development.
and they have that to help them, and we have hopefully a pediatrician that can send someone to Laura Zadak. Then where do people 2 hours west of us have? And it's like, oh shit, if this is what the kids at CHOP are going through that have this here, like what are those kids going through? And that's just like, because I would imagine that like the statistics of that don't change whether you live in Philadelphia or Lakesville.
I thought that was one of the things that they did a good job of highlighting in the study, is like how unfair it is that every single person that they're able to take care of is somebody who's insured or the parents are paying for it out of pocket.
Sorry, I didn't.
Yeah. But it's just, you know what I mean? Like,
But like, yeah, that
so they have
already
this great
skews you so
resource,
much.
but just for the people who.
And
can't
it's still
afford it.
that bad, so it's like,
And bad for the rich white movies.
And it does.
And so it's like,
well, and like,
even
If this is bad, for people who have incredible access.
Yeah.
I fucking imagine.
And it goes back to
Backward
our
South Carolina.
socioeconomic status and vulnerability.
well, and
like
The
where
same
those
population
children
are dealing with the same issue.
and
without any access
Yeah.
to care.
Without state sanctioned
Well, that's the same thing with the surgery and making them do testosterone for a year.
well, but as
Yeah.
as awful as it is we are probably the 0.25% of most understanding, just because we see it all the time, and we see the children with gender dysphoria who come in suicidal, and still like, as wrong as it is, like in my head I'm like, oh my god, they're a minor, like don't they just want to cover their chest up and see if they change their mind? And it's like, I'm supposed to be like the most understanding and the person they can come to, and still like, after I think about it for a second, I'm like, okay, that's wrong, but like still that's my initial reaction because of like how we were all raised and how it all seems. And it's like, I don't know how long it takes to change, but like, at least if we all have to second guess ourselves, then farther down the road you won't. But like, I'm supposed to be the most understanding of all that, and I'm still sometimes like, okay, I don't fully understand, so should I like question them? And that like proves, no, you shouldn't. Or if you see what the CBT does, no, you shouldn't. So
Which is coming out real quick, because I got to go home and watch Jeopardy. Fulfill my-
It is.
honestly, you might as well stay up, because it's about time to wake up and yell at some residents.
You mean Murder, She Wrote?
Jeopardy. But one of the comments you made, and I think this is a corollary, that you talked about the pain and suffering of the physical
Binding.
versus of the binding, the physical versus the mental. And it just shows you that mental illness, people who have significant mental illness will tell you any day of the week they will take the most severe physical pain over the mental pain. And it just bears that out. And so you do have to have a significant respect for mental illness. And the pain that goes with it, which you don't have mental illness, trying to, understand. And I think as a corollary to this, that point, I think it's very, very germane to these kids.
Like, don't pretend to understand them when you can't. It's like you believe,
Accept the
right,
fact
right.
that the pain that they're having is worse than the physical pain that you and I could probably not talk about. They would take that over the mental pain. Just a corollary to that. I mean, that doesn't just,
But it-
not just these kids, it's like
Everything.
I think important, just going back to like the asking pronouns things, is also asking about appropriate name to call the patient. Because I can't tell you how many times I have had a patient that someone has dead named and called the wrong name in front of them, and just how horrible it makes them feel.
Yeah.
Like, so I think like just in that same vein.
I was muttering, would you mind explaining dead names on?
So dead naming is essentially when you call someone by the name that they were given and not the name that they have chosen for themselves.
And it is like he, she, or he, him, she, her.
No,
No,
they're
the
actual.
name is like when
I mean,
they-
is that, no, I know, I'm
That's
asking.
like John to Caitlin.
I'm
Yeah,
asking, I feel
yeah.
like we get caught up on that because
Yes.
of being medical. Is that as like hurtful as the name?
Yeah.
And how do we figure that out? Because we've heard us and nurses say,
Yeah,
oh, well,
also
we
need
have
to-
to know how we're gonna do this or that based on the gender. And it's like, well, do we? So I'm asking, like, cause you understand this
Yeah.
better than me.
So a lot of times when I am talking to someone, especially someone that I know identifies as transgender, I will go in and say, what pronouns are you comfortable with me using? And I always explain my pronouns too, just because then they feel a little bit more comfortable and can say, okay, like I can talk to this person and say, what name would you like to be called? Like, what name should I use when I'm referring to you? When I, talk to my boss doctor about you, what name should I call you? And that usually has gone fine. And
Cecilia has that very helpful she, her, hers on her badge.
yes, I have to get
So how did you become educated enough on that? Like, rather than just what you like see on social media and know is right, like, how did you become educated on like what people might want? Because I feel like that's something that.
but I also, I had a patient as a medical student who was transgender, and I actually sat with him for a very long time and talked to him about what things would make his journey more comfortable in the healthcare realm, and that helped me a lot.
good conversation.
We had a patron on ward in January, February.
I've had multiple patients. I
Well,
don't know
but
which one.
they were
Right.
trans, and the mom was
Oh, the
adamantly
mom didn't
against
want to, yeah.
using
Leonard,
the child.
that was us.
Yeah, the mom
Yes,
was
yes.
adamantly against using
Yes.
the chosen name,
In
but the
same
child was a
room.
teenager.
Yeah, in the same
And
room.
I didn't want to
There's
dead
this-
name the child, but how do you balance not dead naming the child
And
and
the parents being
then-
pissed.
Yeah.
Bye, Dr. Stoller.
exactly like.
Remember they would argue right there.
Don't wear that belt.
Yes, I do quite vividly remember this very uncomfortable experience, which stretched on for several
And the child
days.
was sitting there just devastated, like, you got mothers saying, don't
Yes,
call that.
yeah, it was very,
That was all.
I think I eventually adopted the strategy of like double rounding on them.
Yes, and we would change. the
Yeah,
name.
so we would try to catch the kid alone at least once.
How, as a program director, how much trouble will I get in for
Change.
not even addressing the fucking parent if they say stuff like that?
Well, I mean, I think.
just need a
That's a
baseline.
joke, but I feel
Like, will I
like.
get
Yeah,
kicked?
Yeah.
Like, will I get kicked out because I'm
We all
that's
know that.
Well, I
inappropriate?
do, I mean, and this is not a program, but just as a physician, I think what you do is you try to create therapeutic alliance, right? Of who's my patient, and we are fortunate as pediatricians to have two sets of patients. We have our patient, and then we have the parent's patient, right? Let's be honest, because that's another set of patients. And so you try to create that alliance by talking to them and being honest and being like, listen, your son, daughter, whatever, would prefer this. I'm going to address them when I address them by their name, by what they've chosen, by the pronouns they want. But when I talk to you, I will use whatever you want. Will that work for you? And if it doesn't, trying to understand why it doesn't work for me, because I'm trying to help your son, daughter, whatever. And that might not always work. That might blow up in your face. They may get pissed off and yell at you. But at the same time, you the alliance with that patient. And people want to be pissed off regardless, right? You can do everything right, and a parent's gonna look at you and be like, well, you don't know what the hell you're talking about, right? Where's that other guy at, right? Where's that other woman at? They told me what I wanted to hear. And so some of that is just that.
I feel like that's like an extremely helpful answer, but sounds mean, but when it is 7:15 in the morning and you have 4 minutes,
Yeah,
do you
no,
feel like,
that's
it-
not
no,
what I'm
no, no, no,
talking
I mean, do you feel like it's okay to like just address a patient and like,
Yeah.
when a parent's gonna speak to you, we're not rude, right? They're older than us, I mean, not your mom, but they're older than us, but like, we're obviously gonna respond to them, but like, if they're gonna ask you this and that, and you say, right now, I'm talking to what they
Your
prefer their
child.
name to be, and say, we're gonna come back as a team later and have,
Absolutely.
that's okay, right?
That's absolutely
Because
fine, yeah. Hey, Mom, we'll be back in a
I
little bit.
don't
as a
care, I
team.
never have to round again, I don't care, but I feel like it's important to know, right? But like, your patient is your patient if they're 8 or if they're 10 or.
And it's different when you're around in the morning versus
We all
you're
know you
doing
don't
the
see your
first
patients.
And if the like child is uncomfortable with it, always saying like your child.
Oh, yeah,
is a
your
good-
child is the
Yeah.
wonderful.
Like your
You're like,
child is
this
doing
little
well,
bitch.
this is what we're doing for them, like
For
just
them.
very like, because, and you can
Neutral.
talk to the kid in the that situation,
Oh,
like, do your parents know, like, do you want them to know, is it something that you want me to be like a little more cautious about?
And that's a very
Do you need me
interesting
to open the
situation is
DSM?
when you ask parents to leave
The room.
when your kid is 8 or 9, or when you ask parents to leave when you're not talking about sex.
Yeah.
And those are always weird things, but I think probably if you portray confidence, then
But the more often you have these conversations, because you guys are the generation to have these conversations, right? Dr. Ron and I are not the generation to have this conversation,
Neither
because we're super uncomfortable with these
I know,
conversations.
no, I know.
Like, we never learned to
We
do this,
never-
we never had to do
Lee
this.
was like,
I never
"I've never
heard
had
someone walk back."
smallpox.
Or-
Back when I had polio.
I mean, yo, when we were training, we got so excited, we had one patient that had a fake seizure one time.
I heard you have.
Fake
This is very,
seizure.
I was very excited with that. It's great. But it's, y'all are the generation that's talking about this stuff and normalizing the conversation of using, like, just because it's not in the workup or whatever for chalk doesn't mean you can't do it for your practice. Like, it might not be your practice of chalk, but it's your patient at chalk. And so you can start to have that conversation when you first walk in. And, hey, I'm Dr. Baxter. What name do you prefer to go by? You know, what pronouns would you like me to use during the visit today? There's nothing to stop you from doing that. And then it becomes a habit for you. And then you change your culture wherever you end up going to work.
Yeah, so I always ask the preferred name for everyone, but I never ask preferred pronoun, but I feel like now I'll start doing, and that's just because, and not even in, like, regardless of transgender or whatever, there are so many kids that come in. I just had one yesterday. His name was Jesse, and mom was like, "Oh, he goes by Chris." Well,
Yeah.
Okay, the 3-year-old will go by Chris. So it's like even things like that, and then
What,
so
and
when-
mom says he, and you're like, okay, I don't have to ask.
Yeah.
And then later you're like, oh shit, should I have asked?
Mhm.
I don't know.
They say you're supposed to put on your resume.
yeah,
Oh, really?
yeah, they have
I mean,
it on.
I don't know.
Yeah, it's like on my Instagram and my Twitter and my Facebook.
Really?
Because it's
Is it
now
like
an
the-
option
like
where
the
you can
cis-
do
Like,
it.
there was a cis male or just like pronoun?
No, I wouldn't put
It's just,
that. You don't need to
no,
put that.
no,
Okay.
just pronouns.
Thought this was no
You're
choice.
supposed to.
It is.
That's just Planet Fitness.
And there are websites that
Sexual positions.
specify like different types of binders, so like you don't
Standard
have to
references.
use the ace wrap around your breast that
Preferred
really,
pronouns
really
slash
hurts. You can, there are different types of
I was
binders
just
made specifically for that purpose, like the ace wrap.
Big time bottom.
No, ace wrap is classic. No, dude,
Vaccinated
no,
bottom.
dude, from that. I used to be very subconscious. So,
Really?
you don't have to just use like what people recommend on Twitter. You can use specific products for that purpose that are significantly more comfortable. Like, it doesn't have to be excruciating, depending on your size, unfortunately. Sorry, I didn't mean to lecture.
Where are the
Shut
statistics
up.
to that?
I mean,
Dr. Rickles?
Well, I think the part that's cool
worst study you can get.
Not
It is
necessarily.
super
hard to
impactful, right? Like,
Mhm.
Yeah.
so that's what I think's neat about this.
There are some
This
things
one
you can
that,
only
like-
get through Paul.
Right.
Yeah.
Like the
Policy.
entire field of anthropology does
Yeah.
a very good job
Yeah.
at developing
No,
their
I
statistical
stats
methodology.
Alright, now we're gonna go change the battery.
Yes.
Heather.
Good job, Neicey.
You're done, girl. You're done. Now you have grand rounds.
Yeah, those are really great.
Our
Real
Zoom people,
paper.
any questions for them, they're all.
They're already
No,
gone.
no, it's just Whitney.
Wait, she's the only one that was on?
No, there were others, but they left like 10
I was
minutes
like, oh
ago.
my gosh.
Okay,
Great.
bye,
Is Whitney
Whitney.
off?
I'm